These data were not practice changing, but definitely fuel enthusiasm and definitely feed significant attention to immunotherapy neoadjuvant trials. And that's what we try to do in our institution and other institutions, to look for these immunotherapy agents, especially in these cisplatin unfit, ineligible patients, and see whether we can have some new treatment option down the road for them if these trials are confirming activity and safety. At the same time, we can even build upon cisplatin backbone, and there are now new trials looking at cisplatin plus immunotherapy versus cisplatin-based therapy alone. That's something that is going to be looked at in the near future in order to try to improve upon outcomes in patients with localized disease. At the same time, you have patients who come to us with a radical cystectomy and they never received neoadjuvant chemotherapy, or they received it and they still have muscle invasive residual disease. Those patients, if they cannot, if they never received neoadjuvant chemotherapy before, if they are fit for cisplatin because they never had it before, and they had PT3 or PT4 or node positive disease, we tend to offer them cisplatin-based adjuvant chemotherapy in that setting. However, if they cannot get cisplatin safely or refuse it, or they already had received it neoadjuvantly, we have these immunotherapy clinical trials, and we discussed today some of those trials looking at immune checkpoint inhibitor as single agent in the adjuvant setting after radical cystectomy lymph node dissection, and we try to accrue well in those adjuvant immunotherapy trials.